Title: Assessment of Autism Spectrum Disorder with Children Who Are Deaf, Hard of Hearing, Part 3. Deborah Mood, Ph.D., Colorado School for the Deaf and the Blind. Split screen: the sign language interpreter and our presenter, Deborah Mood, licensed psychologist, who is sitting in front of a solid background. Captions are below on screen.
So I've reviewed a little bit about how those symptoms of autism and tried to give examples of how they can present, both in hearing children. I've talked about ways that they might overlap in some cases for children who are deaf and hard of hearing. And then I've tried to give examples of how to distinguish those symptoms of autism from typical development for children who are deaf and hard of hearing. The classic example that's actually used is the idea, one of the symptoms that's commonly on checklists or screeners for autism is, does your child respond to their name? And so we know that children who have reduced hearing may not respond to their name. However, so that might be perceived as a symptom of autism. However, we know that that's due to their reduced hearing. Having said that, we still get concerned for children with reduced hearing who aren't responding to their name if we know that they should have auditory access to their name. So the child who's deaf and hard of hearing, who has enough access to spoken communication that they can hear when somebody turns on the Thomas the Tank Engine cartoon or calls Thomas in the other room, and they orient to that. But when you walk in the room, they don't look up, or when you call their name, they don't look up, even when they're not engaged in something that's capturing their attention, or in an environment that doesn't have a lot of other noise that would prevent them from being able to discriminate that. Similarly, for children who are deaf and hard of hearing, if they don't respond to other typical ways of getting their attention that are culturally appropriate. Sometimes I've seen children who are deaf who have autism, and I can tap them on the knee or on the leg or wave in front of their visual field, and they don't orient to that. So if they're not orienting to the ways that we expect children who are deaf to orient, we get concerned about a possible autism spectrum disorder. The overall idea here is to think about autism as a model of atypical development, that children are acquiring these skills in ways that differ, that are not just delayed, but that are markedly unique and that differ from typical developmental patterns. The other thing that I want to emphasize is that anytime a child who has reduced hearing or who is hearing loses a developmental skill. So for example, if they stop signing or they stop using spoken words that they've been using for several months spontaneously in different contexts, if they stop making eye contact and stop being socially engaged, or if they lose motor skills that they were able to do previously, in any of those situations, they should be referred for medical follow-up. The reason for this is that those could be symptoms of autism. In a percentage of children who have autism, we do see a developmental regression that often occurs between 12 months and 2 years of age. And so anytime you see that loss, we want to refer for a workup to consider the possibility of an autism spectrum disorder. But the physician will likely also consider other medical explanations for that loss of skill. In the case of children who are deaf and hard of hearing, if they stop speaking, of course, we also want to include their audiologist in that to consider whether there's been a change in their hearing. There are some subpopulations of children who are deaf and hard of hearing who might be more at risk for autism. That is, when we look at the general literature, we see that some syndromes or development or medical differences are more highly correlated with an autism spectrum disorder than in the typical population. These are often very tricky diagnostic workups because just because a child has one of these potential diagnoses doesn't necessarily mean that they will have autism. It just means that they might be more at risk. So in the case of children who have Charge syndrome, who have both visual and hearing differences, they really require a very astute clinical workup for consideration of autism if we're concerned that their social behaviors differ markedly from our expectations of other children who are deafblind. Some of the other potential differences that might be associated with autism include children who are born with symptomatic, who have symptoms of cytomegalovirus or CMV when they're born. In the general literature of children who are hearing, there has been an association between CMV and autism. Anytime that there's been something that has potentially disrupted or changed brain development, that could put you at greater risk for autism. So in some situations, in some cases of prematurity, those children might be at higher risk for an autism spectrum disorder. And there's been one study that had a higher incidence of autism, that showed a higher incidence of autism among individuals with Usher syndrome. Again, for children who have both vision and hearing differences, we really have to make sure that we're clinically distinguishing the expected impact of those differences on their social behavior from a symptom of autism. Both a rule-in process, where we rule in whether they have the behaviors that might be symptomatic of autism, but also a rule-out process, where we consider whether there might be other explanations for those same behaviors. So some of the common conditions that might mimic an autism spectrum disorder include children who have an intellectual disability, whose social skills and communication skills lag behind their same age peers. In the case of an intellectual disability, however, we would expect children to acquire those communicative and social skills at a rate consistent with their development, even though it's delayed compared to other kids their age, different than the atypical patterns of development that we see in autism. Some other things that you might look at are speech and language disorder or communication disorder, ADHD, anxiety disorders, mood disorders, and certain medical conditions can have an impact on the acquisition of language and can sometimes have an impact on the child's behavior. So those could be things like children who have seizure disorders that impact their language acquisition or use. Children who have vision differences, again, can have an impact on their acquisition of many of those early social communication skills and their behavior. So diagnosing autism among children who are deaf and hard of hearing, you may be understanding by this point, is quite complex. And what contributes to that complexity is not just that some of the symptoms might mimic, symptoms of autism might look similar to behaviors that we might typically see in children who are deaf and hard of hearing, like not responding to their name or having a delayed theory of mind. But that the ways that we typically assess an autism spectrum disorder are based on tools that were not developed for children who are deaf and hard of hearing. So they often include items that may be considered unfair for children who are deaf and hard of hearing, either because the child's reduced hearing impacts their access to the skill, like wondering whether the child responds to their name or not, or the ways that we're assessing that look different than how we would expect a child who's typically developing and deaf and hard of hearing to act. Another complicating factor is that there are few providers who are trained both in deafness and in autism. And so that informs their perspective in considering whether a child has an autism spectrum disorder. They might mistake those overlapping symptoms as being indicative of autism when they're really not. Or they might fail to distinguish those unique features of autism, and sometimes we see providers who are not familiar with deafness attributing too much to their hearing loss rather than really understanding the context of that child's behaviors and how those behaviors differ from most children who are deaf and hard of hearing. Again, there's the fact that some of the symptoms might present differently in a sign language versus a spoken language, and if you're not familiar with that, it would make it difficult to assess. And because there are few providers who are trained in both deafness and autism, there are few providers who can provide a direct assessment for children who communicate in a sign modality. And when you think about the symptoms that we talked about that are unique language features in sign language, if you weren't familiar with sign language, it would be very difficult to assess for that via an interpreter. We also don't know how having an interpreter in a room when you're trying to assess for that social interaction between an evaluator and the child might influence and shift that dyad and therefore influence the evaluator's perspective of the child's social behavior. Those are all things that significantly complicate the diagnostic process. Therefore, when assessing for an autism spectrum disorder for a child who's deaf or hard of hearing, best practice really is to refer to a clinician who's familiar with deafness and autism, who can communicate with it directly with the child. If that's not available, and I realize that in most places in the country it's not, it's really important to have really good communication between the evaluator assessing for autism with the child's other professionals who understand and know deafness. So their teachers of the deaf, their interpreter, their speech language therapist, their audiologist, other people who have an expectation of what to expect in terms of the child's acquisition of language and their behavior. It's also really important not to rely on any single assessment tool for diagnosing autism. Instead, we want to have multiple sources of information. We'll talk a little bit more about this. If you have to use an interpreter, again, this is discouraged and not recommended, but if an interpreter must be used, it's really important to prepare them for what to look for. Those symptoms of palm rotations and pronoun avoidance, and asking the interpreter to communicate to you if the child is using signs in ways that are unusual compared to other children who are deaf. That can be very difficult to distinguish from a communication disorder, but at least you'll be preparing the interpreter to be looking for those specific symptoms of autism. It's also important for us as a field to better understand the importance of that communication match between the examiner and the child during an assessment for autism. Right now, that's something that we just don't totally understand. I want to talk briefly about some of the tools that are used for assessing autism in the general population, that is in the population of individuals who are hearing. One thing that I want to caution people is that there are many instruments that are out there that can be used as screening tools or as diagnostic tools for autism. Some of them have better statistical reliability and validity than other instruments. And so even though none of these tools were developed for children who are deaf and hard of hearing, you want to at least start with the instruments that have been shown to have better reliability and validity in the general population. And then try to interpret the results based on an understanding of what autism can look like among children who are deaf and hard of hearing. So one of the tools that is commonly used in screening for an autism spectrum disorder in very young children, about 16 months to 30 months, is called the Modified Checklist for Autism in Toddlers. And there's a revised version available. And it's available, it's in public domain, and it's available online at the website that you see here. It includes a follow-up interview, and again, knowing how autism can present in children who are deaf and hard of hearing will be helpful to you in considering those follow-up questions. There are other tools that are considered screeners, like the Autism Spectrum Screening Questionnaire, which is for children who are ages 6 to 17. Once there has been an established concern for whether a child might specifically have autism versus another developmental difference, there are some other screeners that have been developed to look at that, to look more closely. One of them that's commonly used in schools is called the Childhood Autism Rating Scale. It's now on the 2nd edition. That's for children ages 2 and up. And this is an instrument that uses clinician ratings based on that clinician's observations and parent report. What this means is that it shouldn't just be distributed to anybody to complete. It must be completed by an evaluator who has a solid understanding of autism. And to try to use this tool effectively with a child who's deaf and hard of hearing means that clinician must have a solid understanding not just of autism, but of how it can present in children who are deaf. There are other parent report instruments that are commonly used as screening tools for an autism spectrum disorder. One of the most common ones is called the Social Communication Questionnaire. This is for children who are over age 4 and who have developmental abilities over age 2. This is a questionnaire where parents read questions that are based on a diagnostic interview called the Autism Diagnostic Interview Revised that specifically asks them questions about autism symptoms, and they indicate yes or no. And then you calculate a total score. So if that total score is over a clinical cutoff of 15, then the individual would be referred for a full evaluation. It's available in English and Spanish versions. Again, looking at the items of the social communication questionnaire, some of the items are not necessarily fair or valid for children who are deaf and hard of hearing, or have to be interpreted within a context. And what we've seen clinically is that in many samples of children who are deaf who have been assessed for an autism spectrum disorder, parents often rate their children who have autism as having more of these symptoms than typically developing children who are deaf and hard of hearing, but still is falling below that clinical cutoff that's used as a guideline for autism referral for hearing children. So what this means is if you use this instrument with children who are deaf and hard of hearing, first of all, you really have to interpret the results cautiously. But secondly, even if the child's score technically does not exceed that clinical cutoff, if you have concerns about these red flags for autism that we've talked about today, they should still be referred for a full evaluation. Another tool that's commonly used is the Social Responsiveness Scale, 2nd edition, and that's for children ages 2 through adulthood. There are parent and teacher rating scales for this. This instrument measures behaviors that might be associated with an autism spectrum disorder, but it can also capture developmental differences that might be attributed to another developmental difference that affects social communication and social understanding. Another tool that is commonly used in an assessment for an autism spectrum disorder is a clinical interview that should be given by a professional trained in autism and trained specifically on the tool called the Autism Diagnostic Interview Revised. This is an interview with family members or caregivers or parents of a child or individual that specifically assesses for those symptoms of an autism spectrum disorder. That then yields scores that are mapped onto an algorithm. And again, this is an instrument that has some value in assessing for a possible autism spectrum disorder, but it has to be administered and interpreted with an understanding of how deafness affects the developmental trajectory of a child and how that's distinct from an autism presentation. So in general, for many of the screeners and the tools that we have that were developed for children who are deaf and hard of hearing, even though we might expect on like a surface review of the instrument for a child who's deaf to score as possibly having an autism spectrum disorder, our clinical samples are showing that even when kids are given a diagnosis of autism who are deaf and hard of hearing, their parents often don't endorse enough symptoms to meet that clinical cutoff. And so we have to use these tools very cautiously. However, having said that, if you have an understanding both of deafness and autism, the tools can still have some clinical use in gathering information. But children should be referred for further evaluation, even if their score does not exceed the clinical cutoff, if there are concerns about an autism spectrum disorder. We don't know much about, and we haven't established a clinically agreed upon best practice for assessment of autism among children who are deaf and hard of hearing. But in a hearing population, the gold standard, what's called the gold standard in assessing for autism, is considered the Autism Diagnostic Interview Revised, or a similar developmental and clinical interview that, again, assesses specifically for those symptoms of autism, as well as those rule-outs, those diagnostic rule-outs, and those potential associated features that we talked about earlier. In addition to that, part of the gold standard is use of a tool called the Autism Diagnostic Observation Schedule. We're now on the second edition of that. And finally, clinician's judgment. Again, I want to emphasize that no tool in and of itself should ever be used in diagnosing autism. That's not a hard and fast steady rule how a child scores on a particular tool. Instead, it's the cumulative information that's gathered through this process. I can think of many situations, and especially for children who are deaf and hard of hearing, where they may or may not score on one of the tools that we use for an autism spectrum disorder. But clinically, the cumulative data suggests that a different diagnostic conclusion. There are some efforts underway in Great Britain to validate many of these tools for use with individuals who are deaf and hard of hearing, and we hope to learn from that research to be able to apply it to other sign languages outside of British Sign Language, like adaptations for American Sign Language. Even though we just talked about the caveats to using these assessments for diagnosing autism with children who are deaf and hard of hearing, in an unpublished survey that was distributed to professionals trained in deafness by Dr. Shield and myself, when we asked them how they assessed for an autism spectrum disorder among children who are deaf and hard of hearing, the Autism Diagnostic Observation Schedule, the ADOS-2, was described as the most commonly used instrument. Having said that, there was a lot of variability in the training of the individuals who were using that instrument and how it was being used and modified for children who are deaf and hard of hearing. There are definitely challenges to using the ADOS-2 with children who are deaf and hard of hearing. In fact, if you read the manual, it indicates that the instrument is not recommended for use with individuals with vision or hearing loss. One of the biggest challenges is that in the Autism Diagnostic Observation Schedule, signs are calculated as equivalent to gestures. So rather than perceiving signs to be equivalent to spoken language, the signs, if the tool is used in a standardized way, are considered equivalent to gestures. Currently, there's no agreed upon or research-based understanding of how to use the ADOS. However, In my clinical experience, there's value to using it if you come to the table with understanding both of deafness and autism. Here's an example of why the tool can be challenging when used with children who are deaf and hard of hearing, and why we particularly need to avoid using the scoring algorithms that were developed for hearing children with children who are deaf and hard of hearing. So one of the scoring items on the ADAS is how does the child respond to the examiner or the parent calling the child's name? We've already talked about how this can be impacted by a child's reduced hearing. Another item on the scoring algorithms is the intonation of the child's vocalizations or verbalizations. So we know that sometimes children who are deaf and hard of hearing have a different speech that differs from how hearing children produce speech in some situations. And so we want to be cautious that evaluators who are not familiar with how the child's hearing impacts their spoken language to make sure that they're not overly attributing those differences to symptoms of autism rather than understanding that as a symptom or as related to their hearing. This one's particularly tricky. In the ADAS-2 scoring algorithms, we look at whether a child is using facial expressions that are varied, that match with their affect, and that they direct those facial expressions to others. So a child with autism might smile about something, but direct that smile inward rather than orienting it to someone else, or they might show a limited range of facial expressions. So what gets tricky about this is we have to distinguish that function, and how do we distinguish that from those ASL grammatical features? In a study conducted by Dr. Shield and myself of his sample of deaf children, of deaf adults who were previously given an autism diagnosis, we found that there were significant differences in how they scored on the ADAS, depending on whether we strictly adhered to the standardized guidelines or whether we modified the ADAS in a clinical manner, in a manner consistent with an understanding of sign language and applying the tool to use with children who are deaf and hard of hearing. In that study, on the ADAS-2, there were significant discrepancies between how the children scored on an ADAS module that was clinically decided upon based on understanding deafness or one per standardized instructions. Children who had significant and obvious symptoms of autism were likely to score within the autism range regardless of what module was given to them. However, there was much more variability for children who had more subtle symptoms of autism. The fluent or native signers were most likely to be misdiagnosed if the ADAS-2 was used according to standardized procedures. This was because it generally resulted in administering a Module 1, which for hearing children is given to minimally verbal children. And ADAS would definitely, in many cases, under-identified autism among those children. Therefore, it's important to consider that use of the ADAS-2 is very complex and requires both clinical judgment and knowledge of both autism and deafness in order to appropriately select the module appropriate for that child's communication abilities, as well as knowing how to modify the administration for children who are deaf, as well as how to interpret the results. Generally speaking, the use of the standardized algorithms at this point is not appropriate. Having said this, again, if you have understanding of both deafness and autism, the tool can be useful to you in gathering information to assist with that differential diagnosis. We really need to better understand what modifications to these tools are appropriate. And we have to recognize that the materials may not be as deaf-friendly. So for example, the materials include musical toys, or they're scoring based on how the children play with figurines, and that can look very differently for children who are deaf who are using sign language than hearing children. Several items are also problematic because of the nature of sign language. So there's a task that asks the child to show you and tell you how to perform a task, but in giving those directions, you give away the task due to the iconic nature of some of the signs involved. It's also important to recognize that even if we modify the tool to make it accessible for children who are deaf and hard of hearing, we may not be capturing everything that we need to in assessing for an autism spectrum disorder among children who are deaf and hard of hearing. We wouldn't be capturing, for example, with this tool, whether the child is appropriately using those ASL grammatical facial features that are really important and that we know might present differently among children who are deaf with autism than among typically developing deaf children. We've talked about some of the tools that can be used as part of the assessment process for diagnosing autism among children who are deaf and hard of hearing. And I want to highlight that again, the autism tools, the specific autism tools that we talked about in and of themselves are not sufficient for diagnosing autism. Assessment of autism must include a comprehensive developmental history that specifically looks at those early symptoms of autism as well as possible comorbid conditions or other explanations of the child's behavior. It should include a medical history because, again, in the big picture of things, we know that some of those medical symptoms can impact the child's functioning. It should include a cognitive or developmental assessment and a measure of adaptive functioning because it's important for us when we're considering whether a child has autism, we're really looking at gaps between their developmental abilities and their social skills specifically. And so we have to know where their developmental abilities lie. In children with an autism spectrum disorder, we often also see gaps between their cognitive abilities and their adaptive functioning. And so, again, these are components that can impact the child's quality of life, so they must be included in the assessment. It should include observations of the child's behavior across different settings. And a multidisciplinary evaluation really is ideal to have multiple perspectives about the components of development that might be impacting the child's behavior. Specifically in assessment of autism for children who are deaf and hard of hearing, in addition to those multiple sources of information, it's really best practice to refer to a clinician who's familiar with both deafness and autism. And again, if that's not available, to consult with professionals to establish consultation amongst professionals who understand deafness and those who understand autism. I've included some resources that might be helpful in understanding how autism can present among children who are deaf and hard of hearing, as well as a reference list for additional information. Today we reviewed considerations in assessment of an autism spectrum disorder among children who are deaf and hard of hearing. Look for future broadcasts regarding intervention for autism with children who are deaf and hard of hearing, as well as educational considerations. For questions, I refer you to the resources that I've provided, and my contact information is on the screen as well.
A plain text version of the resources listed here is available on the Outreach Program pages of the CSDB website at www.csdb.org. A production of Outreach Programs, Colorado School for the Deaf and the Blind, 33 North Institute Street, Colorado Springs, Colorado 80903. Telephone 719-578-2100. www.csdb.org. Graphic, the CSDB logo.